911. What's your emergency?
My friend needs help.
What is your location?
I don't know. Let me check. It's 2504 Cassie Lane in Stockton.
What's your name?
My name is Steve.
Okay, Steve. Are either of you hurt?
I don't think so, but my friend, she's on the floor and she's not moving. She's not talking to me anymore. I don't know what to do. What do I do?
Don't hang up. Help is on the way.
Oh my gosh. She wasn't like this earlier. She was talking and everything. She just started to mumble and she doesn't even know where she is anymore. I'm touching her forehead. She's really hot. And she's breathing way too fast. Please hurry.
Stay calm and stay with her. The ambulance will be arriving any minute now. Hi, my name's Yolanda.
Thank goodness. She's right over here on the right.
Do you know how long she's been this way?
I just found her like this. She's been complaining of stomach pain.
May? My name's Yolanda. I'm Yolanda. I'm the paramedics. I'm here to help you. Are you having any pain? She's breathing very rapidly. You know,
I feel very good.
Okay. It's okay. We're here to help you. Her respirations are very fast and her blood pressure is very low. And she's confused. She doesn't know where she's at. We're going to need to take her to the hospital staff right away.
Dr. Nick? Okay, let me put you on speakerphone.
This is paramedic Yolanda inbound to your facility with the sepsis alert. I have a 24-year-old female, altered level of conscious, found mumbling at the site on the floor, complaining of possible abdominal pain. She has a history of type 1 diabetes. Her respirations were 32, her O2 was 88% en room air, blood pressure 70/30, and her temp was 38.9 Celsius with a very thready pulse. I started an 18-gauge IV in the right AC, running 1 liter of normal saline. Our ETA is 3 minutes. Report for standby.
Okay. Prepare bed 3.
Got it, doctor.
Hello, I'm Dr. Nick. I'm going to take a quick listen to your heart and lungs. Okay. Yes, good. Keep the fluids both going. Let's get another 18 gauge on our left AC. Let's get her on broad spectrum antibiotics. Okay, let's get a lactic acid. Let's also do a abdominal x-ray and ultrasound and MRI. Let's do some blood tests, blood cultures, and a UA. You got that, nurse?
I got it.
You look just like the patient.
I don't know what you're talking about.
What you have just witnessed is a representation of a medical emergency known as sepsis. 50 to 60% of all severe sepsis patients are brought in by ambulance. Why is sepsis important? To begin, sepsis is a major health concern in every hospital. It's the #1 reason for hospital readmission, totaling about $27 billion each year. According to the CDC, at least 1.7 million adults in America develop sepsis each year. In addition, approximately 35% of all deaths in a hospital are due to sepsis, making it the #1 cause of deaths in hospital. Even worse, 80% of these deaths could have been prevented. On the brighter side, however, the quicker sepsis is recognized, the better the chances of survival will be. Sepsis, also known as septicemia, is a potentially life-threatening condition that can sometimes go unnoticed due to its subtle signs. With sepsis, infection causes the body to produce an inflammatory response that can damage organs and ultimately cause them to fail. While infection is needed for a diagnosis of sepsis, it is not the infection itself that is the heart of the problem, but the body's overreaction to the infection that is of concern. To put it into perspective, take for example an anaphylactic reaction. For a person who is allergic to a bee sting, it is not the bee sting itself that is the issue. It is the body's response to the bee sting. It might seem like sepsis is caused by only bacteria, but that is not the case. Bacteria is just the most common cause of infection for sepsis. Besides bacteria, sepsis can also be instigated by fungi, protozoans, parasites, and viruses. These infectious agents can make any health condition become a septic one. For example, an appendicitis can rupture and cause widespread infection. Therefore, it's important to realize that if you have a patient who comes in for any type of infection, always keep sepsis in the back of your mind. In addition to health conditions such as cellulitis, pneumonia, and endocarditis that puts a person at risk for sepsis, there are also other factors. These individuals include people who are immunocompromised, such as infants, the elderly, or patients diagnosed with cancer, HIV, AIDS, or diabetes. Diabetics are at increased risk due to the fact that they have compromised wound healing and often have neuropathy of their lower extremities. The neuropathy decreases sensation, not allowing them to notice the wound. Combined with poor wound healing and poor wound management, the wound can easily become infected, leading to sepsis. There are many potential sources for infection to occur. Infectious agents can enter the body through a Foley catheter, an IV site, feeding tube, and chest drainage tube, to name a few. Even a small cut on a finger can possibly lead to sepsis if not taken care of properly. In short, any break in the skin or foreign object inserted into the body can allow opportunistic infectious agents to enter the bloodstream. Although sepsis can turn deadly, early recognition is key to stopping the domino effect sepsis causes. Furthermore, early recognition makes it easier on everyone: family, doctors, and all healthcare providers in the community. The sooner we catch sepsis, the sooner we can implement treatment and the better the outcome. We need to stop sepsis before it becomes a resource-intensive, cost-intensive course of care. Overall goals for sepsis include early detection, resolving the infection, stabilizing blood pressure, maintaining oxygenation, restoring acid-base balance, supporting organ function, and hopefully recovery. This condition is a complex one which requires complete collaboration between all healthcare providers in order to achieve the best possible outcome for the patient.
Infection causes the lining of our blood vessels to become leaky or porous, which leads to fluid and blood leaking out of the blood vessels. All of the fluid and blood that should be going to the heart, lungs, kidney, liver, and brain isn't going to the right places. The body tries to compensate for its inadequacies by changing the heart rate, respiratory rate, vasculature tone, cell production rate, but unfortunately this also results in unwanted waste products. Because fluid is constantly leaking out, blood volume and blood pressure drops. A decrease in blood volume will result in the heart chambers not filling as much, leading to a decreased cardiac output, causing an insufficient mean arterial pressure. The body compensates by increasing the heart rate, but the increased heart rate alone won't increase the blood pressure without adequate blood volume. That is exactly why it is so important to have fluid resuscitation. All of this means hypoperfusion. Less oxygen is delivered to the tissues, and the lungs hyperventilate to counteract the deoxygenation. As cells go from an aerobic metabolic state to an anaerobic one due to cellular hypoxia, increased waste products like carbon dioxide and lactic acid are produced. As more and more organs go without oxygen, their performances dramatically drop and organ failure ensues. A low MAP correlates with a lack of kidney perfusion, causing a decreased GFR, decreased urine output, and an accumulation of waste products in the blood like BUN and creatinine. The lungs fatigue from hypoxia and less carbon dioxide is expelled. The hypercapnic state of the blood can cause neurochanges and ultimately will be shown as an altered mental state. All of this ties in with SEERS, sepsis, severe sepsis, and septic shock criteria. There are 3 stages to sepsis, but how do we differentiate between someone who's sick and someone who's septic? The answer is SIRS, Systemic Inflammatory Response Syndrome. There are 4 different criteria for SIRS: temperature, heart rate, respiratory rate, and WBC and bands. Bands being immature white blood cells due to the rapid production of white blood cells in response to an infection. Having 2 of these identifiers plus a source of infection or suspected infection leads to the diagnosis of sepsis. Severe sepsis is an infection, 2 SEERS criteria, and organ dysfunction. Having even just one significant increase or decrease above or below a certain range can elicit suspicion to severe sepsis, leading to the diagnosis. Septic shock is severe sepsis with a lactic acid greater than 4 or with persistent hypotension, meaning that the MAP stays below 65 and systolic blood pressure under 90 even though fluid resuscitation has already been completed. 3 parts are necessary to preventing shock: an adequate circulatory system, an adequate blood flow, and adequate blood volume. If just one out of the 3 is not sufficient, tissue perfusion is compromised, leading to multiple organ dysfunction syndrome and possible death. There is another way to check for organ failure or impending death, and it is known as QSOFA. QSOFA stands for Quick Sequential Organ Failure Assessment. It involves 3 clinical manifestations: respiratory rate over 22, systolic blood pressure under 100, and an acute onset of altered mental status. A score of 2 more criteria identifies a majority of patients who are at risk for dying. QSOFA and SEERS can both be extremely helpful for all patients, not just possible septic patients. The sooner sepsis is suspected, the sooner treatment is started. Timing of treatment is crucial for patient outcomes. By taking a quick look at this graph, you will notice an inverse relationship. As time goes on with a lack of antibiotics, survival rates drastically decrease. Specifically, why it is imperative to get broad-spectrum antibiotics started immediately. A 1-hour delay can mean life or death. Here are some labs and lab values to look at when dealing with a patient with sepsis. Procalcitonin and C-reactive protein, which are inflammatory markers to check if the body has initiated inflammatory response. CBC to check for leukocytosis, leukopenia, thrombocytopenia, and anemia. ABG to check for acid-base balance and respiratory failure. PT and PTT to assess coagulability, risk of bleeding, and complications such as DIC. And a complete metabolic panel to look for abnormalities like excess CO2, creatinine, and bilirubin. The 5 lab values on the right are some of the criteria needed to diagnose severe sepsis, and all 5 values can be found on the labs on the left. Possible tests to further identify problems are blood cultures, sputum cultures, cerebral spinal fluid cultures, and urine analysis. Blood cultures must be obtained from 2 different venipuncture sites in case one is contaminated. Sputum cultures to check for bacterial pneumonia, CSF cultures to check for meningitis, and UA to determine kidney damage characterized by proteinuria, oliguria, and anuria. While broad-spectrum antibiotics are the initial treatment option, they increase the risk for antibiotic-resistant bacteria, and the patient should be switched to narrow-spectrum antibiotics ASAP. To tell which antibiotic will be most effective, gram stains and susceptibility tests such as minimum inhibitory concentration is utilized. Diagnostic tests include ECG, MRI, CT, X-ray, ultrasound, and much more.